person has them the rest of their life. They reoccur with depression or immune status changes, physical and or emotional stress can cause them to reappear. The lesions of the genital site usually heal within 7 to 14 days, and they reoccur with depression and or immune problems. Why does depression keep coming up in this word?
Because it doesn't go away. Self-esteem issues.
Yeah, because psychosocially, if you're told you have herpes, you can go down in the pits, right? Because you don't understand it. You think now if you've got herpes of like a genitalia type, the doctor tries to explain to you that herpes of your lip is not an STD, but you don't understand that. Plus you're embarrassed you have this big lesion on your lip. So you can develop depression. If you're prone to depression, you will have depression during that time. So you want to make sure that the person understands that their state of depression can cause them to have a lasting effect on the herpes, so it can last longer. The herpes zoster, you've heard a lot about shingles lately, and the problem with herpes zoster is that it affects people 65 years or older, and they tend to be very excruciating when they have them. These people are not young punks in the beginning, right? So they're physiologically, they're older and they're more frail. A lot of people who get herpes zoster also have other health ailments. So they might have cardiac failure, they might have COPD, they might have pulmonary hypertension. Any and all of those kinds of medical diagnoses, or diabetes, can cause this herpes zoster or shingles to last longer on the flare-up because the body's immune system is already under stress with the other infections and diseases. And so, like I said yesterday, it follows a nerve ending on a body. So if you have a person come in with a rash, and the rash goes like this, around like this, and then it comes around back here and it crosses the spine and goes here, it's not shingles. Because shingles stays on one half of the body because each nerve ends at the spinal process and a new nerve starts.
So shingles start.
Pardon me?
So, I'm sorry, I'm just thinking out loud.
Okay, so shingles starts at the nerve root, and what you have is you have these elderly patients start complaining of a pain, like it's always common, it's like a pain right here, or a pain right here, they have a pain right here, and the pain is so bad that they have to come to the doctor. They don't usually come to the doctor, they're there always for their diabetic checks, or their blood pressure checks, or their medication checks. They're coming in today and they're telling you, this pain that's right here is so bad I cannot believe it. I know you don't see anything there, but it hurts. And the doctor will press on it and the patient will respond, so the doctor might treat them like it's a sinus infection. And by giving the body the antibiotics for the sinus infection can aggravate or cause the flare-up to be worse again, because antibiotics work on your immune system. And so what you have is a person who has this ominous pain, and it's really affecting their life. It hurts so bad they don't want to do anything with anyone. They put cold on it, they put heat on it, they might even put Bengay on it, all kinds of ointments, white flower ointment or oil. It's called white flower, and it's like a really heavy minted oil that you drop in your hands, and then you put it where your aching bones and joints are. Not supposed to use it on your face, but people that are coming out in shingles will use it on their face because their face spot hurts so bad. And then within 7 to 14 days of that spot hurting, they'll get this little tiny pimple. And most of them will think it's a pimple. And they'll try and squeeze it, and they can't touch that spot because the face is still hurting so bad. And then within 24 to 48 hours, they have this red line, and a lot of them think what? With a red line?
Infection.
They come to the hospital panicked. I must have an infection. Look at this red line. And we see this little pimple, which is really a shingles onset blister. And if you look really close at the red line, it's a bunch of little red pimple blisters forming, following the nerve. Now it's dangerous to have it in your cheek because when it follows the nerve here, it travels up by your eye, and if it gets into the eye, it can damage the eyeball itself. This shingles will cause pain in that nerve root even after the shingles is all better. The person can suffer years of pain in that nerve root. Shingles is caused by a virus you already have had. You've either been immunized against it or you had it yourself, and that virus is called chickenpox. The chickenpox virus has the same RNA type in the cell as shingles. And what happens is the RNA type from chickenpox settles into your immune system, and when you're stressed or overly ill, you come out with shingles. And as I said, it can take quite a few weeks to fully erupt, and it can take months to get better from the eruption appearance, but it can take years before the pain is gone. So psychosocially, how do you think these people are doing? They're not doing good when they have this extreme pain all the time. This is a herpes zoster or shingles. This is that little pimple that probably appeared first, that little blister right here. And then it's following the nerve ending right across here, and it stops right here mid-sternum. That's because it only affects one nerve. Now, weird thing is, if you get a unilateral case of shingles, which means it's on this nerve and this nerve, unilateral meaning exactly the same on both halves, you actually have to call the Center of Disease Control. Or you have to call your infection control person on site, and they have to report it because it is highly irregular, and the Centers of Disease Control have to monitor the patient. So it's very interesting. If they have a unilateral shingles, it's very reportable to the state and a lot of monitoring. So the diagnostic, how do we say it's shingles and not something else, not an infection? Well, the characteristic explanation, for example, oh, I've had this pain here for weeks. Okay, and then all of a sudden, doctor, I got this bug bite or something. Maybe the bug bite gave me this pain and this blister, I don't know, but now look, it's a blister. And the doctor goes, okay, let me look at that area. Oh, and it burns and it hurts so bad, doc. It's hurting really bad all the way to here. And it's just right here, doc. Or it's just right here, doc. Or right here, doc. Or right here, doc. It's those areas that have a nerve ending that it can follow, okay? And the doc will listen to the patient's statement, look at its characteristic findings, and can culture the lesions and send it to the lab. And it'll come back shingles. And the thing that we do for it is we give analgesics, which are what? Pain medicines non-prescribed, right? Analgesics are your aspirin, your Tylenols. We don't give NSAIDs in this case. NSAIDs cause a lot more symptoms in the patient. We also give them Kenalog lotion, which is a steroid lotion, or corticosteroids to help with the inflammation. It doesn't help with the blisters. It doesn't help with the pain unless you're giving analgesics and the Kenalog. They even give the patient an injection of Kenalog. The best thing the doctor can load the patient up with is a cyclovir, which is an antiviral. And if the patient has all these other disease processes going on, including diabetes, they can't have a cyclovir because it's bad on the liver. So you have to have a good patient history and make sure the patient's healthy enough to take the antiviral. And then the way the antiviral is prescribed is, it's usually an 800 milligram pill. And it'll say something like, start off today taking 1 every 6 hours, increase till 2 every 6 hours, and finally 3 every 6 hours. So over a period of days, you increase these 800 milligram tablets from 1 tablet to 3 tablets every 6 to 8 hours. And so it's this humongous dose, sometimes 2,400 milligrams of a medication before we can get the virus to calm down. And the person can take a cyclovir for a long time because the shingles can last for a long time. A cyclovir is most feasible and worth its weight in gold the first few days that the shingles shows up. After that, if you're on the 3rd or the 5th or even the 14th day, a cyclovir can be still prescribed, but it's not as effective. Okay? We have periodontitis rosacea. We talked about that yesterday. It is a virus, and what it causes is it begins as a single lesion, and it gets real scaly and has a raised pink border. And when it all erupts, it takes a total of 14 days for the whole virus to attack the body and show up with all of its signs. And so it's a, let's see, I believe it's a skin-to-skin contact spreadable. This is what it looks like. As you can see, it's scaly looking here, pink on the outer lining. Okay? The other thing, we're almost done with what we talked about yesterday. We're almost up to the last thing we talked about. Medical management requires no treatment. Take a history of the patient, maybe suggest a veno bath, which are your oatmeal colloids that help soothe itching and help soothe skin irritation. Doctor might recommend the person using 1% hydrocortisone cream. Ultraviolet lights may shorten the length of time of onset of the rosacea looking marks. Cellulitis, we talked very good about that yesterday. It's an inflammation in the deepest layer of the skin to the top layer. So where does it start at? Stratum basal. The stratum basal area, and leads out to the top surface, so it affects the cells, cellulitis. It's a cellular inflammation from deep within the leg to the top surface, and you get this leg or extremity that is very, very red, sometimes swollen so hard it feels tight, and it could be weeping serosanguinous fluids or interstitial fluids. It's a yellowish, light yellowish fluid. There is very high risk of infection secondary to the cellulitis, and we think that an infection causes cellulitis. We aren't too sure. We know that persons with diabetes are more prone to cellulitis, okay? Persons with contact sports are more prone to cellulitis. The chemical manifestations of cellulitis, you have a lot of redness and pain. You have tenderness, you have a vesicle formation. What's vesicle formation? A vesicle is a blister-like formation. So you know when you wear shoes that aren't fitting right on the back of your heel, you develop that watery blister? That's a vesicle, okay? And so you develop these vesicle formations. They can be quite large as a silver dollar on that leg where the cellulitis is appearing. And as it continues to develop or evolve and come out with its complete symptoms, the patient, meanwhile, is complaining of pain, heat, tenderness, irritation, numbness and tingling to their lower part of that leg or that extremity, might have a slight fever. When the doctor examines their groin area of their lymph nodes, he or she will have swollen lymph nodes in their groin area as well. The cellulitis assessment parameters, we want to always use our diagnostic test, which is what? Get a scraping of the fluid, right? Or take a skin biopsy and send it in. Because if they can determine whether it's a streptococcus infection or a Haemophilus influenza, determines how it's treated, okay? Medical management is always controlling the symptoms. You have to help the patient feel better. So the symptoms are steroids to help with the inflammation, creams and ointments to help with the skin's top layer, the epidermis, which is stretched beyond its normal capabilities, so that it's got these little fissures and cracks in it, and the interstitial fluid is weeping out. So there's a chance of dehydration on the patient too. These people, if they're diabetics, their sugars will be sky high because of this cellulitis process going on in their body. Nursing interventions, what are you going to do for that leg that's got cellulitis? Can't hear you, what? If the doctor prescribes antibiotics, you administer antibiotics. What else? elevate, very good, we're elevate depending on how we elevate depends on the part that's inflamed and cellulitis, right? Somebody said something else, pain relief. Very important to make sure these patients are medicated well so that they have good pain relief. Wouldn't we wrap it real well too? In the direction toward the heart, we start at the lowest portion of the leg and come wrapping toward the heart so that we encourage circulation and venous return, so that we can help with some of that congestion in the tissues to get reabsorbed, pushed back into the cells, okay? Impetigo, this is where we left off last night. Very contagious, seen a lot in daycare centers. Staphylococcus aureus is responsible for causing it, as well as strep. Kids that get it get a little blister somewhere, and the mom thinks it's a cold sore, which is still contagious, and sends the kid to school. And within hours, the kid can have an eruption of these little blisters on their face, usually on their face or hands or legs. And the blisters carry inside it either the Staphylococcus aureus or streptococci, which are the parts that are very contagious. As the child or person that has this touches those blisters or those sites that leak, tries to wipe the leaking off, and then touches an item, the next person to come in contact with that item will get impetigo, okay? So it is common in children, highly contagious, and we want to encourage mothers who work. They need to take time off or find auntie or uncle or somebody to watch the kid, because the kid should not go to school with it. They can't go to school until the all honey covered glazed coating is completely done appearing on every impetigo wound, and then you soak the child in warm water to get the honey glaze discharge off. Once the honey glaze discharge is off, it leaves a shiny looking reddened area which is trying to heal. As long as that area dries and has no other discharge to it, it's not contagious, okay? So the removing of the honey colored discharge from impetigo leaves the skin underneath that's been impacted by this microorganism, either strep or staph. You clean it off and it leaves a very shiny reddened area where it's now healing from it, okay? People can have a low-grade fever, and they can also have low white blood cells with the onset. The bacterial disorders of the skin continued. How do we tell it's impetigo, you guys? What does the doctor do again? Culture of the secretion. And then the medical management, nursing interventions. You're going to teach the parents that these sheets on these children, the bed sheets and pillowcases, need to be changed more frequently. And the washcloths and towels and toothbrushes and cups should not be shared with anybody else. I even used to tell parents, when their kids got impetigo or strep throat, buy them a new toothbrush. Because no matter how hard you try and clean that toothbrush, you'll leave one of those microorganisms on it and reinfect the child again. You never want to share washcloths when the children have this, or towels. So when you dry the child off with the towels, you want to put the towels in the laundry already and get them started washing with hot water and hot drying. Antibiotic therapy, the doctor oftentimes will prescribe antibiotics. Medical management, we want to make sure it's not itching. These children that get it are usually 3 and 4-year-olds. They have communication skills but not really good. So we do a lot of watching of the child. If they're continuously scratching, we suggest cortisone cream. If they're saying it hurts and it's in pain, they'll be suggested to take Tylenol, okay? And then nursing interventions, you'll tell the mother, you need to wash the linen, you need to wash the towels and sheets, you need to change the toothbrush, and this gets hard on the parents. They need to stay out of school till all the lesions, the honey-colored discharge and crust that collects on this skin lesion, until all of them have erupted, collected this honey discharge. You bathe the child, get the honey discharge crust to come off of the child, and you're left with these dry, reddened, high glossy sites. Then the child's no longer contagious. But if you dry off the child and they go sit to watch TV, and a few minutes later 1 or 2 or all the sites become honey glazed again, the child still has impetigo and cannot go to school. okay? Folliculitis, barnacles, all these, you guys love the way I say this. I'm changing it. We've talked about all this yesterday. This is ringworm of the head. It's called Tinea capitis, and it causes hair loss. We saw that yesterday. We talked about the clinical manifestations of fungal infections. Let's change here. Contact dermatitis. Contact dermatitis is just what it says. Contact, if you come in contact with it, you can spread the dermatitis to somebody else. However, it's also literally what it says. Something you've come in contact with has given you that red and swollen, sore contact dermatitis. So it used to be our gloves, our latex gloves caused a lot of contact dermatitis before it caused anaphylactic reactions. Sorry. So you want to define or find what object is giving you this contact dermatitis so you can stop using it or buy something new to replace it. If it's detergent, soaps, industrial chemicals, or plants, you need to get rid of them, okay? The clinical manifestations, you have a burning feeling at the site. It becomes pain, pruritus, meaning some redness and itching, edema, and then papules and vesicles. So it starts burning and itching, and you're going like this constantly to the site, continuously irritating it. You cause edema, and then you cause the creation of papulars and vesicles to form again. When it occurs, you need to, as I said, be really good about taking a health history on the patient so you can help them determine why this contact dermatitis is appearing. The intradermal skin testing is the tuberculosis skin testing. Tuberculosis is given intradermally. If the patient cannot figure out what's causing the contact dermatitis, the allergen, the patient will be sent to the allergen doctor, and the doctor will give 2 intradermal injections, one on each forearm, and one will be coccidian and one will be saline. And they're tested because they want to see how your immune system is responding. And then based on their intelligence, they can determine what you're coming in contact with. So it's a big process, it's a big step by the allergenist, but they're doing an intradermal testing if you don't know what's going on. They want to always remove the cause. Sometimes you have to eliminate diet, change diets, because sometimes you get contact dermatitis with diet. Burroughs solution is a solution that we allow the patient with contact dermatitis to soak in. It's soothing. It has some antimicrobial agents in it. The corticosteroids to the lesions helps with inflammation. It's a steroid. The cold compresses is really more psychosocial. It helps with relieve the burning and the pain by cooling the area off. And then antihistamines such as Benadryls are remarkably work very well for patients with contact dermatitis. Makes them dizzy, makes them tired, so you have to tell them don't operate any big machinery for the first few doses you take. See how you're feeling good. If you're feeling well enough to drive and continue your daily activities, then you can, but remember, Benadryl causes dizziness and sleepiness and judgment problems. Other things with dermatitis, the exfoliate dermatitis and dermatitis media canthimosa. The dermatitis ventera is contact with certain plants, causes you to get this. If I get pushed or fall or grab onto a bougainvillea plant, without the plant even puncturing my skin, just wiping my skin on the bougainvillea, I get contact dermatitis on the backs of my hands from it, so I don't touch it. Exfoliative dermatitis is infested by heavy metals, antibiotics, aspirin, codeine, gold, and iodine ingested, and it causes this really bizarre dermatitis on the patient. And then dermatitis medicamentosa is hypersensitivity to medications. Anytime a patient gets contact dermatitis or rashes from a medication, they should stop the medication immediately. Clinical manifestations, you can have mild to medium to severe erythema, which is redness, and pruritus, which is itching. You have vesicles that appear, and these are those looking like blisters everywhere. They're full of fluid. And then you have respiratory distress, especially if it's caused by medication contact dermatitis. You'd be surprised how many patients go into respiratory distress and get to the hospital, and we save them, and we say, you know, what's going on? They go, well, I started my sulfa pill for my bladder infection, and I got this rash on my hands, but it's on my hands, and I didn't think it was anything to do with the sulfa, and so they'll continue to take their sulfa, and then they'll have a full anaphylactic reaction. Medical management of all dermatitises is a colloid solution, which is like your oatmeals. Your lotions and your ointments, corticosteroids are very useful. You want to teach the patient, if they're prescribed 1% or more, they should put the corticosteroid on, their cream on very thinly, because it is absorbed through the skin and it can cause psychological changes if you have too much corticosteroid applied to your skin. It also causes skin changes, thinning out of the skin and all of that problem. So you want to make sure that the patient has a very clear understanding how to apply their lotion. If it's Ventera, then you want to thoroughly wash the affected area, cool with a wet compress, and use calamine. Calamine can be bought in any store. It's kind of that pink orange looking lotion that you put on. It's wet, and then as it dries on the skin, it stays pink and powdery. That helps to resolve this type of allergic reaction. We use it also on chickenpox, right? And then dermatitis medicamosa is you discontinue the drug use. So you stop the medication and you have them use cortisone creams, and that'll help everything go away. Urticaria, what is urticaria? Anybody want to take a guess? Hives for an unknown reason. So when people have urticaria, they really don't know what happened. They don't know if it's an allergic reaction. They don't know if it's drug, food, insects. They can give you an example of a history such as, I got stung by the bee and then I got urticaria. Okay, then we're going to attribute that rash to the bee sting. But if they say I went to the picnic and we all ate the same potato salad that I always eat, we all ate the same hot dogs, and then I came out with this, what would we think? We would just call it urticaria not otherwise specified, because they're saying they've always eaten those things and now they've got this urticaria. If it's, I haven't ate watermelon in years because I was allergic to it and I wanted to see if I was still allergic to it, so they ate it, then it's caused by the watermelon, then they should be recommended never to eat it again because it could cause anaphylactic reaction. Emotional stress, a lot of people, particularly women, when they get overly stressed, they start itching everywhere. And they just itch everywhere. And it causes this extreme, almost mind-crazy feeling of itching everywhere on your body. And that's called urticaria, not otherwise specified either. The clinical manifestations are pruritus, which is itching with redness, burning pain, and wheals. What is a wheal? We talked about a wheal yesterday. It's an elevation of the intradermal skin, right? It's not necessarily, oh yeah, it is. It's fluid filled, and it's an elevation of the intradermal skin. So, what do we do for health histories, and how do we figure out how to heal this urticaria? Sometimes people have urticaria all their life and never know what causes it. There's a good health history. You could send them to the allergenist, who will do a bunch of allergy tests on the patient to figure out what's going on. They'll identify and alleviate the cause. Figure it out. If it's a divorce happening, then you can reassure them that when the divorce is settled, their urticaria will probably go away. Antihistamines, you can prescribe Benadryl. If Benadryl stops working, you can prescribe an antipsychotic from the 1950s called Seroquel or Doxepin. And Doxepin has an antihistamine component of it, which works very good on not otherwise specified urticarias. It's called Doxepin. The therapeutic bath, those are your Aveeno or your colloid, your oatmeal baths. Epinephrine can be given to the patient by injection into the thigh if they have their self-injection pins. And the only time they'd want to use their epinephrine is if all of a sudden they ate something or took something and all of a sudden they have urticaria everywhere, then they'd want to self-inject. But if they actually have urticaria for not otherwise specified and it feels to them that their airway's closing and they're an educated person, they have an EpiPen, you can give them Epi and take them to the hospital right away. Teach patients possible causes and prevention of how to not have urticaria. Angioedema, this is often caused by a blood pressure pill. Does anybody know what blood pressure pill causes this or what type? You guys had it last week. Environmental? No, that's not a blood pressure pill. Verapamil? Is that what you were trying to say?
Oh, maybe.
Yeah, it's oftentimes caused by, I believe it's a beta blocker class. And so what happens is one side of the face will have swelling and the eyelid will be swollen and the mouth, well, it actually starts with their tongue. Their tongue will be swollen. And usually when they feel like their tongue is swollen, they won't take anything else and come to the hospital. Because I don't mean it feels like it's a little swollen. They're like not able to talk. They're and you give them a piece of paper and they tell you, my tongue is swollen. I can't talk. And then their lips and everything get swollen. Their eyelids, hands, feet, tongue, larynx. So what kind of precautions do you have to be ready for if this person is starting to swell everywhere from a medication? Airway stability. You got to be ready to put in an airway if this worsens while you're standing there. Some offenders of urticaria develop this angioedema, so you have to give education on if your tongue swells, you need to get to the hospital right away because it's a sign of an allergic reaction. The clinical manifestations, the burning, the pruritus is the redness and itching, the acute GI tract pain, respiratory distress in the larynx, gets swollen, edema of the entire area, the eyelid, the feet, the lips, etc. Medical management, nursing interventions, pharmacological. If they're on a beta blocker and a causative, they're going to change the patient type of medication. You're going to give them antihistamines, epinephrine, and corticosteroids to help with their inflammation, itching, and symptoms. And you always want to supply comfort measures because when a patient has angioedema, it's very scary to them. They're afraid that it's going to leave their face looking like it does, and they're also afraid that they're going to die from it. Eczema. This is very common in children. This has a lot of psychosocial issues that can be developed because of eczema. Eczema can appear on a face, on arms, anywhere in the body. It is a sudden onset of a red and scaly looking patch on the patient's body, and it can become numerous within minutes or hours. So we do a lot of allergen tests to figure out if it's something that is causing this atopic dermatitis or eczema. We know that people who have in their family line, if they have people with emphysema, what's it called? If they have the deteriorating rheumatoid arthritis, if they have the deteriorating rheumatoid arthritis or emphysema, these persons have the gene for eczema, and it can be passed to the next person, and usually children, and they get eczema flare-ups. The eczema, like I said, can be all over the body or just one or two patches here and there. We need to know how it's occurring and why it's occurring, so we do an antigen testing on the patient. There have papillars and vesicles on the scalp, forehead, cheeks, neck, and extremities. I saw a little girl that was from Korea that used to come to the dermatology clinic to stand inside the UVA booth. And she would stand inside it with these goggles on and these gloves on, and her orders were by the doctor to every 5 minutes rotate in this UVA booth to treat the eczema all over her body. And she was in 2nd grade, and I could not believe what a brave girl she was. We always talked to her when she came in, how's your friends and everything. Oh, I had to tell another friend that I don't have cooties. They said this was cooties. I had to tell them it was eczema. You know, and she had several environmental allergies as well as food allergies, so she was having these. The erythema and dryness to the area can be intense, and the pruritus, the itching, can be very intense. So what do? We take a good history, look at that heredity. We take a diet elimination. We talk about berries and melons are typical to cause eczema in patients. They're the fruit that has the highest amount of allergic components in it that people are most likely allergic to, melons and berries. And so we ask, you know, if it's summer and they have an eczema flare-up, what could they have been eating a lot of? Melons, right? Watermelon, cantaloupe, honeydew, all that stuff. We do a skin testing, and that gets sent to a pathologist who can better study the skin under the microscope of the affected patch. So they dissect a portion of the affected patch off the patient, send it to the pathologist who will look at it microscopically and test it against different agents to see if it is a food or medicine induced. Corticosteroids help with inflammation. This funny coal tar preparations is sold just as that coal tar, and it's a black shampoo that stains your scalp. It smells horrible, and the child has to wash their hair with it, and also their body sites where the eczema is. And so to tell a child you're going to smell like this when you're done is not a fun thing for a child. They like to be clean and smell clean too. And then reduce exposure to the allergens, always. Hydration's very important in these people. With all this vesicles and swelling going on, a lot of hydration is lost. Lotions, you can use, there's that Eucerin. Remember I told you they refer to Eucerin a lot. There's the Alpha Carry, Lubriderm, the Cruel 3, and 4 times a day. You would put these lotions on those sites and the areas of those sites 3 to 4 times a day. Acne vulgaris. I've seen one recent of these, but otherwise with the creation of Retin A and the knowledge of acne, people don't usually get acne vulgaris as bad as it used to be in the 50s and 60s. But I did see somebody with it recently that was really bad. It's caused by occluded oil glands. So all these thousands of oil glands on your area that the acne vulgaris is appearing have become blocked. And in turn, they develop this white blister type of form over them, which is the white blood cells coming to the rescue of a microorganism irritation. They have androgens that increase the size of the oil glands. Influencing factors, your diet. If it's high in soda and chocolates and caffeine, you're prone to have more acne. Stress definitely breaks people out. Heredity, if your parents had acne vulgaris, you have acne vulgaris. And overactive hormones. So teens that are going through puberty, overactive hormones can suddenly develop acne vulgaris, which to me is a mean trick to do to teens. They have such a hard time adjusting to their state of mind anyway as a teenager. And now they have this look at me appearance on their face, because you know everybody looks at them when they have this. This is a really reddened face, oftentimes edematous face, with big zits everywhere on their face. And sometimes you're trying to talk to somebody with it, you see so many whiteheads, you're thinking, let me just, you can't say nothing to them, you know. One time I had a guy in high school talking to me, and he smiled and it ruptured right here, and it just started dripping a little bit of white stuff right here, and I was like, okay, I'll talk to you later. So their face can be very tender and edema. Oily, shiny skin is typical. Pustulars, that's the whitehead-filled acne spots that are occluded glands, and they can have condones, which are blackheads. Have you ever had a blackhead that you have squeezed and squeezed and squeezed and squeezed, and it never comes out, and you create this big sore on your face or location, and the blackhead's still going, haha, I'm still here. And then scarring from the traumatized lesions. This is such an excessive stretch on the skin. It causes traumatization to the skin cells, and they develop scars all over where the acne vulgaris was. So the diagnostic test, they're going to take a really good history. They're going to make sure that they inspect the lesions to make sure they're just acne vulgaris. And they're going to do blood samples for the androgen level in the patient, because if the androgen levels are high, they have more acne vulgaris symptoms. Also for girls, if you have more estrogen than progesterone in your young days, you will develop acne vulgaris. So the medical management, everybody's heard of Retin-A, haven't you? Retin-A, have you heard of Retin-A? Retin-A is a lotion made with is an ointment made with vitamin A and other antigens to it, and if the person applied it to their skin, they had to use sunblock because it makes your skin highly vulnerable to sunburn. But what it does is it works on the top surface of your skin and works its way down, because your skin absorbs, and it works its way down and it applies the vitamin A component to your lower levels of your dermis and such, and it helps to resolve the inflammation that are heading upward and prevent the next flare-up. The Retin-A can cause a lot of redness when you're using it, sensitivity to sun, and peeling to the face. You also want to advise the patient, if they want to become pregnant in the next month or 6 months, they should not use this Retin-A. The topical therapies, the benzoyl peroxide, those are your scrubs. The vitamin A acids, those are your Retin-A's. The antibiotics and the sulfa zinc lotions. All of these you have to give very good advice to the patient to use sunscreen, especially where they're applying these lotions. Keep the skin clean. If you over clean your skin, you can cause the acne vulgaris to get worse. So keep the skin clean. Keep your hands and hair away from your face. And then wash hair daily. A lot of people don't like to wash their hair daily. They say it makes their hair unhealthy. But if you have acne vulgaris, you're one person that should be washing your hair daily. And then water-based makeup. Don't get any of this last 18 hours or won't smudge in water type of makeup. You have to have water-based makeup that'll wash off right away. Psoriasis, same family as eczema. Psoriasis comes on and causes the patient a lot of discomfort as well. A lot of psychosocial interaction there. When they have psoriasis all over their body, people oftentimes think they're very contagious, and they're not. It's a non-infectious skin cell divide more rapidly than normal, and it causes red and raised, circumcised silvery scaling plaques, and the plaques are peelable. You see people with psoriasis peeling their psoriasis. You have to tell them, don't peel that, especially in the public area. And then it's located sometimes on the scalp, the elbows, knees, chin, and trunk. Have you had old patients that have white scaly knees? And they tell, huh? I can't hear you. You're saying something good, so say it. The skin, well, you know, dust in your house is skin particles. Dust in your house, besides being dirt that blows through the air, is predominantly your family's skin particles that have fallen off of you. So skin particles that fall off, it's just gross. There's a YouTube video that's out that someone took of this lady who's dressed in an office attire dress, pumps. She's sitting on the train looking out the window. She doesn't think anyone's looking at her. And she's got one leg crossed like this, sitting flat on the chair. She's got a shoe on, but she can get to her heel right here. And she's literally picking her heel and eating it. And this person over here is videotaping it. And she doesn't even know it. You'd be shocked how many people eat their skin. A lot of people eat their skin, and it's kind of disturbing. You're all grossed out right now, but you might be the one that does it. How many of you bite your nails? You're eating your skin. How many of you bite your cuticles? You're eating your skin. How many of you bite a blister? You're eating your skin. So the psoriasis scares people. People don't understand psoriasis. They step away from people when they have bad psoriasis. Elderly people have a lot of incidences of psoriasis because they're polypharmacies. You've heard that term before about elderly? Polypharmaceuticals. That means they have many drugs in their body system to keep them being elderly alive, right? Most persons over 65 years old, according to the census, take anywhere from 7 to 20 pills a day. Most persons over 65 years old take 7 to 20 pills a day to keep them in the position that they're even living in right then. So they could have psoriasis or eczema from the pills, but what do? If they don't have good follow-up, we'll never know that. And so these persons are the persons that use a lot of creams, and they call it, oh, it's my flare-up, my psoriasis, so forth. They treat it themselves. The psoriasis, topical steroids works great. Ketolytic agents. What's a ketolytic? What does that mean? It dissolves the serotonin because a psoriasis is a bunch of rapid evolving serotonin cells causing the psoriasis type of skin flare-up. And then tar preparations. Here's that tar preparation, and it is made from a derivative from tar, so it smells like tar. It is black and runny, and patients don't like it. They feel very upset when they get prescribed that they have to use this tar preparation. Then salicylic acid, we use this salicylic acid also for acne. It causes a very rapid peeling of the skin, so it helps the psoriasis calm down and peel away. Phototherapy, PUVA, this is a dermatological booth that the dermatologist orders the amount of PU as well as VA rays to hit this patient to help clear up the psoriasis. Oral solriamfetol, you've heard of these pills on the market now. You hear them on commercial. I used to have psoriasis real bad. I take I can't remember the name of one right now, every day, and now my psoriasis is gone, right? And then ultraviolet light. Systemic lupus erythemia. This one is very, very bad, and my sister and I used to have a better time together when we didn't get so busy with our jobs and our children. We used to sit by my pool in Covina when we lived in Covina, and she would say, Pam, you're a nurse. Look at this mole on the back of my head right here. How come when I'm in the sun it hurts? And I go, what do you mean it hurts? She goes, it hurts. When I sit in the sun and the heat starts shining on it, it hurts. And I go, really? Your whole scalp hurts or just that mole? Just the mole. So I moved her hair. She has very black hair, and I moved her hair, and I could see what I call a skinless, colorless mole. Looks like a wart, but it's a mole. It's a lot bigger. And I told her maybe you should have it checked. It's has no color to it, doesn't look dangerous, but you should probably have it checked because it's so sensitive to the heat, and that's not normal. So she went in to have it checked, and before that, she and I were working with her because she kept having over years a lot of weird symptoms. She had a headache for 9 months. She had fatigue that they tried to diagnose as fibromyalgia, but I educated her, if you don't have all 12 points of pain, you don't have fibromyalgia. So you have to have all 12 points of pain, so don't let a doctor put you on fibromyalgia medicine unless he is absolutely 100% sure that's what you have. And then the best medicine for fibromyalgia is an antidepressant to help your autoimmune system relax and calm down. Okay, so she had all these things just compiling with no definite diagnosis. So she went in and had this skinless, colorless mole removed. And we were all waiting for the report to come back, and when it came back SLE. And SLE is systemic lupus erythemia modus. I say erythemia. That just helps me say it better. I can pronounce words terribly, but patients have always been sympathetic with me when they see the spelling of things. They're like, I don't know what I would call that either. And so patients will also have their own nicknames for things. And so you just say, oh yeah, that is your heart pill. you know, but you might know that it's a beta blocker and something else, but to them, that's their heart pill, you know. So anyway, she had SLE. Well, she had to go in for more biopsies located on her other parts of her body and make sure that it wasn't just located right here. And when she had these other biopsies, she came out with, each time she came out with different forms of lupus. So she was one of 10 people in the United States that had all 3 forms of lupus. And so when she got diagnosed, it was a good time she got diagnosed, because USC was just starting a study on people with lupus. So her doctor referred her to it right away. She did a chemotherapy agent IV infusions for about 3 months, and it completely stopped her immune system. She lost all her hair, eyebrows, arm hair, everywhere you have hair, she lost it. And she's since then regained a few eyebrows and eyelashes and all of her hair on the head, but the rest of the body never regained its hair. She doesn't care, it saves on waxing. And the chemotherapy was what it said it would do. It shut down her immune system and restarted it. And when it restarted, it didn't remember it had lupus. So far she's been in remission, which is a good thing. So it's an autoimmune disorder. It means your own body internally is attacking your organs, including your skin cells. And when it attacks your skin cells, it causes these non-colored moles to appear that are highly sensitive to heat, that you must get looked at. Inflammation of almost any part of the body can, when they walk out in the heat, they can all of a sudden become really edematous or really red and feel horrible, and they have heat intolerance. Their joints, their skin, their kidneys, and serous membranes are all affected by this. So they have a lot of excruciating pain that they cannot define. It affects women more than men, especially young women between the ages of 25 and 40. There's an SLE website that all of you, especially African American or half African American, should look at, because you're more prone to having SLE than Caucasian. And it's more hidden in you than it is in Caucasian. If my sister didn't have the lump dissected, I honestly believe she'd either be dead or they'd still be trying to scratch their head and figure out what's going on, because MRIs, CAT scans, blood tests, all that didn't show anything. Her RNA factor, which is your rheumatoid factor, was perfect, 1 to 40, no different, all the time. So that's not the definitive. Her ELISA smear, if you've heard of the ELISA smear, it was also, it's a rheumatoid test, was normal. The contributing factors are immunological, hormonal, genetic, and viral. Now, genetic played an important role in her having this. She is the first in all 3 generations to have this, but we all have the gene for it, and it's the gene that causes emphysema, arthritis, and osteoarthritis. That same gene, when it's manipulated, causes SLE, and so she got SLE. The systemic lupus clinical manifestations: erythema, butterfly rash. This butterfly rash, don't get it mistaken with women in labor, okay? If your girlfriend's in labor and you see her and you just learned about this butterfly rash and you see the butterfly rash, you go, oh, girlfriend, you got lupus. Besides being in labor, you got lupus. No. The butterfly rash appears on pregnant women too, so make sure you know who you're calling lupus, okay? The butterfly rash is very common, and it can be mistaken for rosacea. And what it does is it affects just this area of the face, and so it's called a butterfly because it looks like the butterfly's body and the wings of the butterfly, and it becomes very, very pink, sometimes really reddened area when they're having a flare-up. Alopecia is hair loss. Her hair loss was directly related to the chemotherapy, but a lot of people with SLE, because it's changing all of the autoimmune system is attacking every cell in your body with SLE. So even your skin cells, which create keratin, won't be able to create keratin, so you can have permanent baldness. Photosensitivity, this was a big one. She would walk outside and it didn't matter if she had a ball cap on and sunglasses, her eyes would start tearing dramatically in the sunlight. That was another clue we had to learn about. Oral ulcers, she never had that, but a lot of people with SLE have oral ulcers along the lip and gum line. Polyarthritis or polyarthritis, this is joint pain, severe joint pain in many joints at one time with inflammation or without inflammation. She did have this, and we thought she was having early arthritis symptoms. Pleural cage pain, which means when they take a breath in, their lungs hurt to inflate and deflate. It just hurts really bad in that pleural cavity. They can get pleural effusions, pericarditis, and vasculitis. Renal disorders, usually when the immune system attacks, it attacks all your organs and cells, so it'll shut the kidneys completely down. It could be permanent on many of these SLE patients. Neurologically, because again, it's the immune system attacking itself, it goes straight past the blood-brain barrier, attacks the brain. And so it can cause tumors, growths, and seizures onset. And hematological changes in your white blood cell count versus your red blood cell count. You have extremely weird definitive findings that you're thinking, what is this? This is the butterfly rash. Can you see the wings of the butterfly? And the body of the butterfly? That is very characteristic of lupus. Without this going up here to the eyes, this is characteristic of rosacea. And then a woman in labor, without it being this far on the cheeks, it'll stop right about here at the bottom of their eyes. They'll have that. And so you got to know what you're looking at, okay? You got to define, is it a complete butterfly rash where it completely goes above the eyelids and over to the sides of the face, also encompassing some of the chin? That's lupus. If it's just on the cheeks and nose and goes over to the hairline but doesn't go up to the eyelids, that's rosacea. If it goes halfway on the cheeks like this and over the nose, that's a woman in labor. And they call it oftentimes in the labor department a raccoon mask. Have you heard of that? The raccooning of a woman in labor? That's what it means. Okay, so systemic lupus erythemia diagnostic tests. We're almost done for the morning, guys, as far as it's 11:15. We're gonna go to 11:30 and then lunch break. So we have the anti-nuclear antibody, and I have to tell you, every single one of these was normal on my sister. It was the mole that defined it. So everything was normal except the mole, and then they started looking at all her years of symptoms and they put it together. So medicine is not perfect, is it? That's why it's called practice. We are still practicing at trying to discover what's going on. Yes?
So does that mean they cut it in time because everything else was normal and it was just the mole that showed it?
In time, we don't think so, because she had all those symptoms for a long time. And she was becoming pretty miserable with those symptoms and no diagnosis. It plays a lot on your psyche when you're constantly going to the doctor hurting and they can't give you a definitive answer. Don't we always want a diagnosis? I don't know about you, but if something hurts me and I go to the doctor, and like for example, my knee is killing me right now, and it's killing me for 3 different reasons, so I know it's supposed to hurt me, okay? So if I go get an MRI, which will be normal, they'll say to me, oh, maybe you strained it or sprained it. And I'll say, how can you say that when it hurts so bad, right? And they'll tell you Motrin. You're not happy with that, are you? Wouldn't you rather hear it's torn or broken? Okay, so these people, this is the ANA, and it'll come out a little elevated. The DNA antibody will be very changed. The complement blood tests will be very changed. CBCs will look kind of normal, or can show, if you get a differential, it'll show an elevation in the WBC cells. They can have erythrocyte blastosis, where they have so many overproductive red blood cells being put out in their bloodstream that they're rupturing very quickly and not able to do what they're doing. They can have an increased sedimentation rate, which means they can have bleeding happen more frequently in them. Coagulation profile will be ordered. Rheumatoid factor, there it is, that's that genetic predisposition. Rapid plasma reagents, skin and renal biopsy, she had that. C-reactive protein. C-reactive protein, remember, this is a normal panel test for people who are ruling out lupus. All of these things are looked at along with the symptoms in order to diagnose it. So, figuratively speaking, to the practice of medicine, all of these things and their unique properties will be slightly different in people with lupus. And that's how we finally say A is all your symptoms, B is your blood test, C equals lupus. But if A is all your symptoms and B is all your tests normal, except all of a sudden the biopsies, they showed it. So there it was. A Combs test. Where else do we do a Combs test? You might not know because you don't have labor and delivery yet, but we do it with Rh negative women. So these tests work for other reasons, don't they? Chest x-rays we do on people with chest pain or problems breathing or anything like that. So all of these tests can be for different elements, but when they're put all like this together right now, we're talking about an SLE screening, okay? So the medical management interventions have to be very aggressive. There's no cure. You treat the symptoms. You help to induce or help to extend remission. You try and alleviate the exacerbations, which are those arthritic flare-ups and those headaches that last 9 months. Pharmacological management, they give them non-steroidal medications, anti-malaria medications. Now, why would we give them anti-malaria? Well, the one thing the malaria works on is your immune system. And so if we believe your immune system's attacking it, we're give the immune system something else to focus on. So now when we give you the anti-malaria or the malaria medications, it's going to focus on that malaria and let down on some of those symptoms that it's causing. Corticoid steroids, anti-neoplastic drugs, those are your cancer, your chemotherapeutic agents. Anti-infective agents, only when they really are sure there's infection, because you don't want to give an SLE flare-up antibiotics, because it puts another stress on the immune system and causes their flare-up to be worsened. Avoid direct sunlight at all opportunities. She dresses different now, so she doesn't wear the short shorts and the bikinis out in the sun anymore, both because we're older, we've had kids, but also because of her SLE. So she makes sure that if she's wearing shorts, she's able to stand in shade a lot. And balance, rest, and exercise. She does that very well. She also completely changed her diet to a vegan diet, and she's more of a vegan than my vegan son-in-law and vegan daughter-in-law. And she has a very balanced diet. The only thing symptoms she was left with after the chemotherapy agent was an imbalance in her sugar, inability to balance her sugar, so she gets a lot of hypoglycemic episodes. So she always carries around candies and protein bars and stuff like that to help her body not have so many hypoglycemic episodes. Here's your nice kindergarten preschool symptom. Kids wave, bye-bye mama, I'm going to school. First day of kindergarten, they come home with a letter. Letter's always blue in color, and it's always from the school nurse, and it says, "Dear parents, hope you've had a wonderful start to the new year. Hope your child learns a lot with us. We just want to tell you that a child came to school with lice today, and here's what you need to do. You need to examine the child's hair all the way down to the scalp. You need to go through the scalp area very carefully. All parts of the head completely need to be examined. You're looking for, attached at the hair follicle root, you are looking for little white eggs attached to the hair follicle. It only likes moist hair. So the advantage is the African Americans don't get lice ever. So that's they're lucky. They're lucky there. The Hispanics are the fortunate ones that bring the lice to school. Now why? No,
We're the best.
we're the lower, you guys are usually lower income, less accessibility to proper education about what it is. So it's just something that, you know, the kids are always inching their heads. You don't have the financial ability to take the sheets off the bed every day and wash them like you have to when there's lice. So the lice, there's 3 types. There's the head lice, which is the capitis. If I change the head lice word to Tinea capitis, we have what? Tinea capitis, we have what? Ringworm, right? On the head. Now we have head lice or capitis, which is just representative of lice. It attaches to the hair shaft and lays its egg. The body lice is the corpus, and those are really gross to see on people. And they're found around the neck, wrists, thighs, and folds, wherever your elbows, in between your fingers. And what you get is this petechiae looking rash in between the fingers. This is from scabies onset. And then the pubic lice, crabs. And I had a patient come in, a gentleman, looked pretty business type, beard and mustache, and he was saying, I want to see the doctor. And I said, okay, what's wrong? Can I take your temperature? Mm-mm. I need to see the doctor. And I'm like, okay, let me take your blood pressure. So can you tell me what reason you're here for? And he won't let go. I need to see the doctor. Okay, take him to the room, set him on the table, write down patient states, need to see the doctor. You don't pry, you guys. So I go out of the room and the doctor comes in and he opens the door and he says, Pam, bring me a urine specimen cup, please, and a pair of fine tweezers. Oh, okay. So I go get a urine specimen cup and a pair of fine tweezers and I bring it to him. He opens the door, he's got gloves on, he turns around, shuts the door. And a few minutes later he comes out and says, Pam, look at this. In the bottom of the bottle, crabs. He had oral compilation with somebody with crabs and got it in his beard and mustache. Hey, Mama, what's that white stuff walking around down there? Don't worry about it, baby. I mean, don't you look? You know what I mean? Don't you look? Turn the lights off. I already talked about that to my OB class. Had a lady come into the ER with like 2 teeth, white lady with 2 teeth. So we knew she's not economically feasible, right? She probably can't see anybody but this special ER visit. And she had kind of an accent from like Kentucky, y'all. And she said, y'all, I'm here because my boyfriend, my man last night, he said something smelled funny down there. Okay, put her in the room, put her feet up in stirrups. As I'm putting her feet up in stirrups, green slime, which is trichomonas. Green, frothy. So I put chucks underneath to catch it. I'm like, yeah, something probably did smell funny, but he was down there. I'm all, doesn't he look?
It wasn't. He should have smelled it.
Okay, so the clinical manifestations of lice. Are we ready? Kids have lots of itching. They will scratch their heads so much. Scratch. Now, contrary to what people tell you, lice cannot fly. So the kid has to literally have lice and come up and talk to his friend and bump heads with them for the lice to get onto him. It has to come head to head. Hair to hair contact for lice. If you share hairbrushes, of course, because why? The hair shaft comes off it as you brush your hair, and attached to it is the egg. So now you share brushes and put the egg into your hair. Now the lice multiply very, very rapidly. They lay a lot of eggs, and the eggs hatch at the hair follicle, and they live off of the sebaceous fluid from the hair follicle. So that's why oily hair people, like all of us, except our African Americans, have head lice at times. The only way to get rid of it is really you need some money to get rid of it, because you've got to buy the lice shampoo, the lice comb. You've got to take all the linen off the bed. You've got to wash it in extremely hot, greater than 180 degrees. You've got to dry it in the hottest available drying cycle. And then you've got to vacuum the entire carpeting along the edges of the floor and bed where the bed is. Otherwise you won't get rid of lice. And to do this every single day, as long as you find the little eggs attached to the hair. You'll see lice walking on the scalp, but you're not worried about them. You're looking for the eggs, because those are the things that continue to breed and bring more lice. And the comb they sell you is a little stainless steel looking silver comb, and it gets to the root of the hair and strips the hair, so kids don't like it. It hurts. And it strips the eggs off of the hair shaft. And so as you comb, you have to make sure you have paper under the child. You have to have knowledge to have paper under the child. And you want to catch everything on the paper as well as contain everything when you clean the comb out in a bag, right? You don't want to take it and go, ew, look at that. Ew, you had so much in your hair. Right? Because now you're going to have it. The best thing to do at night for a child that has it is to put the shampoo on it and then comb it out, and then leaving the shampoo on it, put a pair of nylons, the part that goes on your body, clip the legs off and tie them in a knot, and take the part that goes on your body, spread it over the child's head because it's so thick knit, and cover the entire head surface. And when the child goes to sleep, all those louse will die. Even the eggs will die. And then you take the nylons off in the morning, rinse the child's head. Now you have to be careful because the louse shampoo can be very irritating to your child. It is an insecticide. There are very rare cases, but there is a chance that your child could die from the insecticide absorbing too much of it. So you got to be really careful. So you always want to ask the doctor's recommendations of dosage of louse shampoo you should buy. And then it can cause petechiae, little reddened spots where they've scratched excessively on their scalp. It causes severe pruritus, severe itching. Excoriation, there have red scratch marks going where they've scratched here and then dragged their nail down here and excoriated their skin and scratched here. Kids don't scratch with one finger, they scratch with all fingers, and they touch everything including their friends. And so lice and crabs is only spread, and hair scabies is only spread by intimate contact. So scabies, you have to have skin to skin. So when my nurses used to take care of scabies patients and break out with scabies, I knew they didn't follow proper isolation. Even if they say, oh, Pam, I even tucked my isolation gown into my sleeve. There was no skin visible. Okay, how did you take your gown off? How did you take your gloves off? Because you had to, at one point, have exposure, and usually their exposure is upper chest first, which means they reached up here with their dirty gloves, grabbed the gown to pull it off, and went like this and touched their skin as they were pulling it off. They put their dirty glove that had maybe one scabie on it. That's all the scabie needed, was that piece of skin. This is louse attached to the hair. These are the bugs. And then as you get way up here, there's the eggs that are attached. But you will literally see when you ride the Metrolink every day to work like I used to, you'll see people in there that you don't want to sit next to because they will have lice on their hair, especially the homeless get free rides. And so it's the way they cool off, is they get inside the Metrolink or the Red Line and they just sit for hours in there, and they're smelly and lice and everything. So, okay, so the medical management, we have the Lidocaine, the Quail shampoo, we have the Ridge shampoo, the topical steroids, cool compresses, assess all contacts. That's why the school's sending home the letter. They want everybody in that class, because we don't know who touched heads with this child, right? Or who used their brush or whatever. Wash bed linens, clothes in hot water, there it is. Properly clean furniture and non-washable materials. A lot of people don't even own a vacuum, they just sweep their carpets. You can't do that with head lice. And then with scabies, the itch mite, scabies or the itch mite is transmitted by prolonged contact with the infected person. So usually the people that got my scabies were the CNAs giving bed baths, because they're in there a long time. I would watch them practice their work, and they would lean on the bed like this, and they would turn the patient over and their gown would slide up. I was a CNA for 12 years, so I know what it's like. I was a CNA, an LVN, and an RN. Been there, done it, understand it completely. So I had to do a lot of education to my nurses' aides, because they did not understand that any piece of skin this itch mite can come in contact with will make the itch mite happy, and the female burrows immediately under the skin and lays anywhere from 12 to 70 eggs. The eggs are under the skin, and as they hatch, the little mites, itch mites, are wanting out of that burrow. So they come out of the burrow and spread across the skin, and the females look for ways to burrow and for a guy to sperm them. That's all they have in life to do. So they burrow, they get spermed, and they hatch. So within hours, you can be totally infested in itch mites from head to toe. The skin can look wavy, brown. You have these always, okay, this is a scratch from my plant, but this is a great example because I love doing yard work. Okay, so an itch mite scratch, this would have been where this is where the thorn hit me and then scratched, but this would have been the burrow. And the trick to seeing the burrow is you get a flashlight and you get mineral oil. This is an old army trick. And you put the drop of mineral oil on the burrow because they can't breathe if the burrow is occluded. And you shine the mineral oil you shine the light on it with a woods lamp over it, and you literally see the itch mite come out of the burrow to get out to get a breath of air. But this would be the tunneling that they would burrow to. Okay, so they entered here, they entered here and they would leave a line like this as they burrow. So the patient gets these red lines oftentimes in their wrist areas, in the folds of their arms, in the groin area. Elderly people, you lift up their boobs, they have these red scratchy lines. You think, God, they're itching so much. They have scabies. And so it looks just like this, the line, okay? So if you are CNA working right now and you saw your patient, you gave a bed bath, lifted her boobs, and saw a bunch of red lines like this, and she's not able to really scratch, but you think it was scratching, she's got scabies. So you need to have the doctor look at it, get a dermatologist referral and get it treated, or you're gonna have it everywhere throughout the facility. Yes, what? Oh, lunchtime.
Yeah,
Yay! Don't just